Hello, guys. I hope you've been well. You're okay. So, today we are going to check on midwifery, that is a nursing unit. Now, this is the thing. Before I start, I want to help you and introduce something like to those people who are not familiar with Medical Students Arena portal. When I mean MSA, I mean Medical Students Arena, not Mombasa, like some people assume it to be. Now, this is the front page for any student who logs in this portal. These are e-learning portal. That's got the textbook, the notes, the past papers. Okay, here are the buttons to avail. Now, this is the thing. Uh, at a quick review, maybe access to the note, you only need to come and click program unit. Like today, we're going to do reproductive health, that's just midwifery, okay? So we come and click there, and then it opens up. On this page, you realize you have year one, year two, year three. Year four is basically more practical, but then you can access them direct by just a single click. This is the thing. If I want to check on introduction to RH and midwifery, I simply come and click on that button and then introduction to RH and midwifery. Then I read more. On reading more, you wait for it to load. It depends with the size of the document which is there, and then you can read it easily. So if you have our app, you are lucky because when a teacher is teaching you and you're readily availed with all the resources that the teacher is using, you're going to be the smart student in the class. Now, here is the case. Today, we're going to do midwifery. And that is a nursing unit covered in year two, second semester, and first semester. Some people delay on the syllabus and they can even cover it in year three. But that is it. So, today, we are going to check on what we call FANC schedule of visit. That is Focus Antenatal Care schedule of visit. Okay. So, FANC. I know people know ANC. ANC is antenatal care. Then F, which is added, is just for focus. Okay. So we are going to check on those scheduled visit. What are you supposed to be doing when the mom come, the first visit, second visit, and when exactly the mom's supposed to come on the first, second, third, and fourth. Actually, the World Health Organization is kind of increasing the number of visits, but the general number which was used initially and has been used always is four visits. Okay. Some funny women don't even go to one. They don't even go to one single visit, okay? So they fail to attend to facility or health checkup for any other option when they are pregnant. So a pregnant mother is expected to go to the hospital for many purposes, okay? So apart from for diagnosis of pregnancy, also to check and determine the health status of the baby and all that. Now, today on the midwifery, as I've said, we are going to check on the FANC schedule of visit. That is focus antenatal care. Okay. Now, there are many reasons why someone must go to the hospital. Unlike in traditional African society where we had Nyamrerwa, Wakunga, this midwifery, the home-based midwifery, they have several different names, different depending with different tribes. Okay, so today in this growing world, a parent or any mother who is pregnant supposed to go to the facility in the hospital. If you're gravid, you're supposed to go to the. So there are many things which happens there. So those are the visits which we classify into four. World Health Organization might increase them, but the minimum visit is four. So it's recommended that the pregnant woman should attend a minimum of four comprehensive personalized antenatal visits spread out during the entire pregnancy, during which specific focused activities are carried out. First visit should be less than 16 weeks. Second visit should be between 16 to 28 weeks. Third visit from 28 to 32 weeks. And the fourth visit, 32 to 40 weeks. I hope you're good. Now, depending on individual needs, some women will require additional visit. Like yesterday in my practice area, I realized another woman just decided to come the fifth because wasn't even he wasn't contented by the ultrasound result that she had obtained in the last visit, so she had to come in again and go for the radiography to be taken again. So it depends with the individual need. You cannot limit them. Okay, maybe they have a burning issue, maybe there's a complication. Maybe some have got low abdominal pain. Maybe some have started having the labor pain or some sort of. So they'll always be worried. Some are even unfamiliar. Like for preemies, the ones who are having their first time with pregnancy. Okay, so that is all. So the first visit, the very first visit, should take place as early as possible, if possible during the first trimester. And this visit provide the midwife with an opportunity to obtain what we call the baseline data, such as weight, blood pressure. It is so the baseline data are important because they form a basis for comparison during subsequent visit. So what happens is always that registration. Nowadays we have the ANC book, which is actually a detailed book, antenatal care book. That booklet, kind of, it has all the requirement, that it has all the assessment questions, and it has all the modulation that are used to monitor and evaluate, and also to help in preventing any complication. If you go through that book, you end up getting it right. So registration is one thing which is very, very important. Height, weight measurement is taken, history taking. We have, if you're so short, there's a problem. Okay, I don't know about being too tall, but a short stature is always one of the risk factor for any complication. Delivery. So history taking, we take history on that very day, and that NC book has got also a questionnaire for the history taking, so you don't need to remember what you're taught in class. Physical examination is also being done. That is to do with the per abdominal examination, and the per abdominal that just do the inspection. Okay, we actually inspection ultrasound, then you do palpation, percussion, then you can report. So this is the thing. Physical examination is also very important. You take head to toe physical examination and systemic physical examination, from the respiratory, from the genitourinary, into the cardiovascular, central nervous system, the NS. Now, this is the thing that normally you guys you tend to do in the practicing field. You just assume and you go direct to the stomach and maybe per abdomen and all that in abdominal region. Let me tell you something. You might be missing a very important thing that could be very crucial during the gestation period. So, for anything and for any other reason of no doubt, don't allow yourself to just forget what you are taught in class. You are supposed to do a head to toe examination. A mother who has got STI will present with many things on physical examination and genital urinary region, especially if they are ulcerative or if they are, genital ulcer diseases. So you get to know, even if they are embarrassed to tell you in physical ground, you can deduce and know by yourself. So once you know, you will help. You are supposed to help a patient. You're supposed to help someone. You're not supposed to fear someone. Is supposed to help. You will not help if you have fear to go and examine and assess and find. Okay, we do NC profile, laboratory examination. NC profile, they are VDRL for syphilis. We do HIV. We do hemoglobin. HBs. Okay, we check for HBs because at that moment the baby is also using the blood. So if the HBs are low, we can end up having fainting cases, syncope, sometimes dizziness, and all that. So ANC profile has got some list of tests are supposed to be done in the laboratory and the result given. Management of complaints, immunization is also done the first visit, health education as well. So personal history, we normally start with biodata: name, age, physical address, telephone number, marital status, education level, primary, secondary, university. Nowadays, you ask a mother, say education level, tell you secondary, form 4. Some are even class 8 dropout. So you're also supposed to be keen whether they're lying to you or not. Because you might assume, because this guy is in secondary, oh, this one is a wonderful one. I don't need to explain something, can figure out by herself. The problem is that herself might be only a dropout in class 2 or class 3. So check on their face when you're asking them this question. Marital status, find some are pregnant but they are not married. So they get embarrassment when they tell you that they are single or they are not married. Okay, so this is the thing also should always deduce very well when they're telling you. Some will refuse to tell you. Okay, but some, if you force them, they'll give you a false number, because when you rule marital status in that NC book, this is where you write the number of the spouse, okay, or the husband. So if they give you a false number in one way or the other during the clinic, that is the antenatal clinic, you'll end up one day contacting a different or a stranger. So be very accurate and try to reinforce accurate data from the client. Okay, yeah, ask about economic resources, employee, type of work, position of patient and husband. Okay, so that you don't start being so figurative and objective oriented in a way that you cannot even check around and consider a fair pricing of the service, because you can even force somebody to go for ultrasound. This one is of low socioeconomic status, therefore they're not able to get the money to finance all those processes. So you can at least space off. If they were necessitated 3 ultrasound, you can at least reduce it to 1. Tobacco use. Ask about tobacco use as well. History of present pregnancy, present obstetric history. This is always in the NC card, so you don't need all those parameters that you need to fill. So just question the clients. Then you are supposed to obtain information on date of last menstrual period. Focus on the certainty of dates, that is by regularity, accuracy, or recall, and other relevant information, including contraceptive history. Okay, because there are some contraceptive which will not allow the mother to actually have a clean, clean follow up or maybe tracing of her last menstrual period. So somebody is on Depo Prevera, has some irregular periods or maybe jumpy. So when you ask the last menstrual period, be even confused because it is a norm when you're on some of the family planning drugs, you won't get your period as consistent and regular. So you need to also to know now accurately determine the expected date of delivery based on the last menstrual period. Okay, so EDD, what called the EDD, can be calculated by adding 7 days to the first day of the last normal menstrual period and subtracting 3 months from that month. For example, if our last period started on 18th June, so you do 18 plus 7, give you 25. Then June minus 3 months, okay, will give you March, okay? So the EDD is March 25th of the following year. So it's always the following year, especially if the last measure period is not at the beginning of this year, okay? Yeah. Yeah, so that is that. So you need to obtain information on quickening if applicable, and you really need to know when the quickening start. In the field there, you realize some start noticing movement or fetal movement or somatic movement or even gross fetal movement. The mom can get it and she can understand that there's something in my abdomen. So that process, those movement of the fetus, we call them quickening. It always started from 16 to 22, but then most of them start getting this at 18 weeks. Okay, so check for any associated complication: pain, vaginal bleeding, calf muscle pain. Calf muscle pain will give you to know whether there is any risk or any future glimpse of DVT, deep venous thrombosis. Okay, check on vaginal bleeding because that one can give us what we call antepartum hemorrhage. Okay, pain and all that. And vaginal bleeding can even denote many things apart from abortion, miscarriage, and all those possibilities. Social habits: smoking, chewing tobacco, alcohol, drugs, frequency, and quantity. Okay, now, just few days ago, I was somewhere and then this woman was saying, nilipigwa na chupa kwa club, nikamwaga maji, sijasikia mtoto wangu for at least 1 week. That's dangerous. You see, if these are drunkard, they're always going to stay in the club the whole night, doing drugs, associating with dangerous people. You should really sensitize, and in fact, the relatives should also be involved on the same. Previous obstetric history: number of previous pregnancy, date, month, year, and outcome of each event: live birth, stillbirth, neonate death, abortion, ectopic, either TD form, mole, number of NC attendance, type of deliveries, duration of labor, birth weight, sex, puparium, specify type and gestation of any abortion and management if possible. Do an MVA, ask about MVA. Okay, the director and curate deliveries, birth weight of previous pregnancy if known, period of exclusive breastfeeding, when and for how long. Okay, so special maternal complications and events in previous pregnancy, specify which pregnancy, validate by records if possible, recurrent early abortion, induced abortion, and any associated complication, thrombosis, embolus, breech, or transverse presentation. Take history on any obstetrical operation, cesarean section, indication if known, forcible vacuum extraction, manual removal of placenta, destructive procedures like craniotomy, decapitation. Also, obtain information on twins pregnancy. Low birth weight, like less than 2.5 kgs, 2,500 grams. Intrauterine growth restriction, rhesus antibody like hydrops, malformed or chromosomal abnormal child, macrosomic, that is at 4.5 kilogram newborn, that is a large baby, we call them macrosomic. Resuscitation or other treatment of newborn, perinatal, neonatal, or infant death. Okay, medical surgical history is also important. Now, on medical surgical history, specify if there is any history of surgery, specific disease and condition. Ask. Now, if it's medical, you ask about tuberculosis, heart diseases, chronic renal diseases, epilepsy, diabetes, mellitus, and all that. Now, HIV status, if known, other specific conditions depending on prevalence in the region, like hepatitis, malaria, sickle cell trait, operations other than cesarean section, ask them, okay? Blood transfusion, has she ever had a blood transfusion, ratios, these negative antibodies, current use of medicine. You need to specify this and any other disease, past or chronic. Okay. On gynecological history, obtain information related to manage. That is when the breast came out. Okay. Oh, I mean, manage that is when the period start to flow. Okay, the beginning of the menstrual period. Menstrual history, gynecological disorder, reproductive tract infection. Ask about that. Then ask about family planning. Inquire on previous use of contraception, if any, frequency, duration. On this part, obtain information on any non-hereditary condition, the family, significant illness in the family, such as diabetes, social, and on social history, obtain data on occupation, diet, exercise, smoking, alcohol, marital status, level of education. All that is very important. Then now what is very, very important is now perform physical examination. A third examination is made at the first visit. This is divided into general examination and obstetric examination. So on general examination, and we really need to know the aims of physical examination of pregnant woman is to diagnose the pregnancy. You need to confirm this pregnancy rumor or something, to identify high risk pregnancy and to give advice for pregnant mother. So on the general examination, before we go to obstetric examination, we check on general appearance, namely like nutritional status, whether weak or sick looking, not the gait, and if she walks with a limp. Height, noting that any woman below 150 centimeters in height is likely to have cephalopelvic disproportion. Are we together? A short lady, any height below 150 centimeters is likely to have a cephalopelvic disproportion. Weight, that is a pregnant woman on average gains 2 kg every month. The total weight gain by the end of pregnancy is about 10 to 20 kilograms. Okay, excessive weight gain indicates accumulation of fluid in the tissue like edema. So lack of increase in weight or loss may mean malnutrition. Obesity may lead to an increased risk of gestational diabetes, so you should check on the obesity and advise on diet. If it is calorie intensive, reduce the calories. We have a given chart which will always help you to outline and give appropriate diet on instruction or counseling to the expecting mother. Blood pressure, which is taken in order to ascertain the normal and provide baseline for comparison. A pressure of 140 90 over 90 millimeters of mercury at booking is indicative of hypertension and could cause damage to the placenta. So check on the pulse, temperature, signs of anemia in conjunctiva, hands and tongue, pale complexion, fingernails, conjunctiva, oral mucosa, tip of tongue and shortness of breath. Check of edema of face, hands and ankle. Observe type of breathing and chest, generally for abnormality. FGM step. If type 3, discuss the possibility of defibrillation, opening up either antenatal or during labor. Check on varicosity, warts, discharge, breast examination. Okay. Uh, Palpate gently with the flat of the hand to feel for any lumps. Check if the nipple is what we call the protactile. Then you need to educate the woman on how to examine the breast by herself. For further reference on breast examination, we'll talk on that. But if you're a nurse, you can go to nursing council procedure manual, and then you get that. So abdominal examination, we always check for observing for signs of pregnancy, assessing fetal size and growth, assessing fetal health, diagnose the location of fetal part, detecting any deviation from the normal. Step of abdominal examination: one, inspection; two, palpation; three, auscultation. Okay, so that is just the inspection has got 5 S. Check on the shape, not the counter. Is it round, oval, irregular, pendulous, longitudinal, avoid in primigravida. Longitudinal if you, it's supposed to be ovoid, okay, in primigravida, round in multipara, broad in tracheus, what we call the transverse lie, okay. Now, size should respond to the supposed period of gestation. Skin, the dark line of pigmentation which is linear negative seen any rash. Stria gravidarum, scar, any operation scar, check on that. On palpation, use the Leopold's maneuver. There are 4 steps in Leopold maneuver. The first is fundal light and fundal palpation. That's the first Leopold maneuver. During this examine, you need to check the fundal light. At about 12 to 14 weeks of pregnancy, the uterus is palpated above the symphysis pubis as a firm globular sphere. It reaches the umbilicus at 20 to 22 weeks and the symphysoid process at 36 weeks, and then often return to about 4 centimeter below the symphysoid due to lightening at 40 weeks. Okay, so measure distance of fundus with the points on abdomen and assessing the fundal height in finger breadth below the symphysternum. or measure by centimeter. Okay, so fundal palpation, to know lie and presentation, we do the fundal palpation. So use two hand, using palms of hand, palpate on either side of the fundus, and then the finger held close together, palpate the upper pole of the uterus and feel that as it is hard, as soft or regular. Note it. Is it hard? Is it soft? Is it regular? Okay. So lateral palpation, let's say the second Laporte maneuver, to know the lion position, just like the fundal palpation. Okay, always facing the mother. Fix the hand on the center of the abdomen. Fix the right hand. I don't know if you're getting me. Fix the hand on the center of the abdomen. Fix the right hand and palpate with the left, vice versa. Not the regularity, and the regular side is the back. Okay. Now, deep pelvic palpation. That is the third Leopard maneuver, to know the presentation and attitude. Feel presenting part. Is it hard or soft? While palpating for the presenting part, feel for eminences on back side. Pollix grip, the last one. Okay. So I've talked about the fundal, the lateral palpation, the deep pelvic palpation, and the Pollix grips. The lower pole of the uterus is grasped with the right hand, the midway facing the woman's head. Feel the occiput and sinciput, not which is low. Okay. I don't know if you guys have understood what I've said. The lower pole of the uterus is grasped with the right hand, and the midway face the woman's head. Okay. Face the woman's head. Feel the occiput and sinciput, not which is low. Okay. So on those images, you can see the fourth maneuver, the first maneuver, the fundal light. Okay. And then the second maneuver, okay, and then the fourth maneuver. Okay, so this is fundal height, this is lateral palpation, this is deep pelvic palpation to know the presenting part, then fourth maneuver, check on the occiput and sinciput. Okay, now that is that. So before we go to auscultation and all that, I think that's enough for examination today. So prepare for your examination just in the groups. Have a nice time, and don't always forget to create an account in Medical Students Arena.